It's my distinct pleasure to introduce the first speaker, Dr. Ambrose Isah, who's with the University of Benin in Benin City, Nigeria, where he serves as professor of clinical pharmacology and therapeutics, as well as consulting physician. It's been my pleasure to know him for a number of years, and he is going to be presenting on proposed set of indicators for monitoring and evaluation for pharmacovigilance activities. Doctor and Professor.
Yeah, moderators, rapporteurs, distinguished ladies and gentlemen. The title of my presentation is the proposed set of indicators for monitoring and evaluation of pharmacovigilance activities by myself, Paul Shanti of WHO Geneva, and Sten Olsen of the UMC Uppsala, Sweden. You'll all recall that there was a flurry of pharmaceutical activities in the mid-20th century, which was welcomed with great excitement and indeed euphoria. However, this was truncated by the thalidomide episode of the late 1950s and the early 1960s. This tragedy kindled global consciousness regarding the need to monitor the safety of medicines. The immediate response of the developed countries was to establish pharmacovigilance systems, which has grown tremendously over the last 50 years from simple collecting outfits for adverse drug reactions to a very sophisticated pharmacovigilance system. Of interest, however, is the lack of a standard set of indicators to measure and monitor pharmacovigilance activities and enable comparison of relating to the baseline periods as well as established trends of pharmacovigilance activities. Furthermore, there are no indices for comparison of measures for inter- and intra-country region as well as facilities. The essence of this presentation is to provide objective measures which will enable the assessment of the status of pharmacovigilance, the activities, its impact globally at all levels of the healthcare system with a view to ensuring patient safety. Specifically, it will outline a set of indicators for monitoring and evaluating pharmacovigilance activities, and also provide a tool for measuring changes in the pharmacovigilance system, as well as the impact of pharmacovigilance interventions. The slides I have for methodology have been constructed by my slide quota, but essentially, the methodology entailed wide consultation and consensus in identifying a set of candidate indicators and revised from several sources. Initially, from a detailed review of the established pharmacovigilance systems, that is looking into the processes, the routines, and also relevant literature sources. Contributions also from various stakeholders and pharmacovigilance experts affiliated to the National Pharmacovigilance Centers, which were also the focus for a survey to further categorize the indicators. The others included the Pharmacovigilance Sans Frontier, a group of experts in Africa affiliated or with further support from Uppsala as well as WHO Geneva. And the WHO Advisory Committee on Safety of Medicinal Products, which helped in validation of the indicator set. And eminently, the WHO Monitoring Center in Uppsala. Now, the framework categorized the indicators into structural, process, outcome, and impact indicators. In parentheses, that which is, you will find the numbers indicating the total number of candidate indicators. And for the structural indicators, assess the key pharmacovigilance infrastructure in the various settings and elements which give pharmacovigilance some visibility, as well as the legal and policy instruments. For the process indicators, it included those that assess the degree of pharmacovigilance activities. And then the outcome impact included those which measure the effects, usually long-term, of pharmacovigilance activities. And you find also beneath the subcategory core and complementary. In parentheses is the number of the core indicators, I think, which I'll focus on. It's also important to note the background information, which provides information about the pharmacovigilance milieu, that is the setting where the indicator is operating or being implemented. And this will include the demographics, things like the population, the gender, age structure, and things like the hospital numbers, disposition, personnel, and a host of other things to give the information about the milieu. And this is very important because you find that the background information provides, to a large extent, the denominator for calculation of the indices. Subcategorized are the core and the complementary indicators. You find that the core indicators are considered to be highly relevant, important, and useful in characterizing the pharmacovigilance, and they should be stated. It's important that the core indicators are stated at all times when comparative work is being done with the pharmacovigilance indices. The complementary indicators further characterize pharmacovigilance, but need not, be mentioned, in all instances. I will go on to just give a few examples. That's on the core indicators. That's the core structural indicators are exemplified. There you have the 9 of them. You find the first one is there a pharmacovigilance unit, department, or center, which positions a structure or a setting for pharmacovigilance and gives it, some visibility. Same with the legal provision there, and then the Drug Regulatory Authority, number 3, which to a large extent is very useful in pharmacovigilance activities. And then the sustainability is taken care of by number 4, which talks about the financial arrangement or provision of a statutory budget for the center. And then 5 talks about personnel disposition, 6 about case management, whether you have a case management in place. And then you go right down to the end, 9, which talks about curricular provision. That is, do you have pharmacovigilance within the professional training curricula? This is very important. And as you see, it's a yes-no thing, since what is intended, the answers here are essentially qualitative. For the core process indicators, again, it looks at the activities of pharmacovigilance in the centers, and you find the first one telling you about the total number of ADRO reports received in the last year, and expressing it as per 100,000 persons in the population. And secondly, the total number of reports that you have in the database, which is very important, and I think with trends, you can see it's usually a beautiful picture from the pilot studies we've carried out. And then percentage of total annual reports, issued informative feedback. This ought to be a very important activity within pharmacovigilance setups, the issuance of feedback. And then percentage of total reports subjected to causality assessment, which again is very important, and advisory committees should play a role. And you go down to talk about the number 7, number of total medication errors, which is a very important area, usually suppressed, in pharmacovigilance work. And then 8, what proportion of pharmaceutical industries have a functional pharmacovigilance system, which is important. And then the average number of reports per pharmaceutical industry per year, so as to make sure or ensure that the pharmaceutical industry buys into the pharmacovigilance system within the country. Then the core outcome or impact indicators, which you find here, you measure maybe more periodically because it's more intensive in assessing this, will include like the signals generated in the last 5 years, the number of medicine-related hospital admissions per 1,000 admissions, telling you about the admission or the effects of medicines, which you can monitor over time if properly applied. Number of medicines-related deaths per 100,000 population. The medicines-related deaths per 1,000 persons admitted into hospital. This is more useful for hospital facilities. And the number of regulatory actions taken in the preceding year consequent on pharmacovigilance activities. The label changes, the safety warnings, the drug withdrawals. And then the average cost of treatment of medicines-related illnesses. And I think if you look at the study of Ben Mohammed, the one in UK, I think that might even put this indicator in proper perspective. And then you talk about the average cost incurred for medicines-related hospitalization and the average work school days lost due to drug-related problems. So now you find that the other important, sorry, not going back or what? Okay, yeah, thank you. You find that for public health programs, they are a unique group which has to be addressed, and an indicator set ought to be applied within public health programs so that pharmacovigilance could be properly monitored. And here you find that there's a mix of both structural, the process, as well as the core, the outcome impact indicators. You want to, one, is there a pharmacovigilance system in place? It's important that public health programs have that. And then you talk about the presence of a standard reporting form, containing the essential elements. And you talk about the total number of adverse reports in the database, the total number of reports per 1,000 patients per population, and you go right down, to more of impact, telling you about the number of medicines-related hospital admissions per 1,000 admissions, especially relating to some drugs which might be deployed in some programs. And we know that a lot of drugs are being deployed, in public health programs. And then the number of medicine-related deaths per 1,000 persons admitted into hospital. So in essence, Mr. Chairman, ladies and gentlemen, I think this set of indicators will provide useful, simple, robust, not requiring high technical expertise, as a tool to monitor and evaluate pharmacovigilance activities at various levels of the healthcare system. They also serve as indices for comparison of pharmacovigilance activities at country, regional, and facility levels, and within public health programs. And the availability of these indicators will enable monitoring of the impact of policy provisions and interventions in the pharmacovigilance system. Thank you very much.
Thank you very much. We're going to allow for up to 3 questions of a clarification manner if any of you would like to do so, given that the material is fresh on everyone's mind. And if you wouldn't mind just stating who you are, it would be great. Thank you. I don't think the microphone's on.
Thank you. My name is Peter Pitts. I'm with the Center for Medicine and the Public Interest in the United States. You mentioned as one of your core process indicators functional pharmacovigilance systems for pharmaceutical companies. Clearly, I certainly agree with that. During this conference, we're talking quite a bit about increasing the robustness of generic prescribing and usage, and yet most generic companies do not have their own proprietary pharmacovigilance systems. Adverse events are generally reported using the innovator product. Do you feel that needs to change, especially as we move into an era of biosimilars?
No, are you saying that it should focus just on the innovator product?
No, what I'm saying is most generic companies throughout the world do not have adverse event intake systems that the adverse event reports go to the innovator company.
Yes, I think I'll quickly say that we have to get all companies or market authorization holders to buy into this, even generic companies, because you find that the volume of drugs, being deployed by generic companies are huge, it's large. So we cannot excuse them. And what we are talking about is adverse drug reactions from drugs. It does not differentiate between the original, the MAH holder, or a new generic company. So I think everybody should have that. And I think we should encourage all generic companies to also have pharmacovigilance systems of their own, in-house pharmacovigilance systems. It's not just made for the large or big, very big companies. Both national, local manufacturers should have at least some outfit, to meet the criteria. Thank you.
One more clarifying question from the back there. Thank you.
Thank you. Kumud Kafle from Nepal. I have two questions. Number one, where this data would be generated? I mean, using these indicators, number one. And number two, who will analyze and who will collect this data and will analyze?
No, what's the first question?
Where this data will be collected?
Okay, yes. Well, I did not show the data sources, on this slide, but you find that there are different sources of the data. You have even census figures. You also have national databases. You have registers, and then you have the pharmacovigilance centers in the various countries and all that. You find that for a number of the indices, the reports will go into the national pharmacovigilance centers where they can calculate most of the things, especially the process indicators about what is going on. And hospitals, even regions, have their own pharmacovigilance outfits. They should be able to carry out some form of calculation or obtain the indices in those settings. For large surveys, that has to be planned. I can't show that here, but that is, over years, because you have to plan it, carry it out, maybe in form of an epidemiological survey and all that. So it depends on what of the indicator. The methodology for that, I can make that available to you, if you to get that. So the second question was on. Can you come again with that? Analyze it. No, it depends on what data you have, and what you're talking about. For the structural indicators, they are mainly qualitative. Do you have a pharmacovigilance center, yes or no? If it's at the national level, that will be answered by the officers or officials in the National Pharmacovigilance Center. If it is for hospital level, it will be answered by the hospital pharmacovigilance officers. So that is, is quite simple if you address it depending on what facility or outfit you want to assess.
Thank you, Dr. Isah.
Yes. And I think, let me, belatedly, I think I must acknowledge the various persons who contributed to this.
We have one more hand up.
Okay.
Is this a clarifying question, or do you want to save it for the discussion period?
Okay. Can ask it. Let's see.
Okay, shall I just ask? The name is Fatima Faizu from Management Sciences for Health. And I'd just like to ask a question is that we're collecting information, and some of the indicators require very detailed information that assumes that there are already systems in place. So unless facilities are actually collecting information and have some sort of an active pharmacovigilance program within their healthcare facilities that's collecting information on medication-related deaths or events related to hospital stays and so forth, how are we actually going to get the information for these indicators?
May I suggest we hold that answer for later?
Okay.
That's an outstanding question.
Yes.
And
Okay.
thank you for the question. So our next topic is the quality of medicines in South Africa, perceptions and reality. It's my pleasure to introduce Aarti Patel, who is with the Health Research in Action, or HERA, program in Belgium, and she indicated she did the work while she was at the University of Otago in New Zealand. Thank you very much.
Thank you. Good afternoon to everyone, and I'd like to thank the ISIM organizers for inviting me to the conference. The topic of my presentation is quality of medicines in South Africa, and I was exploring perceptions of quality and comparing that to the actual quality of medicines. And I'd like to acknowledge Pauline Norris, Robin Gould, and Thomas Radus, who are also part of this work. Now, we are at an ISIM conference, so all of us are very clear in terms of our understanding of the concept of the essential medicine. It's about the medicine being available, affordable, it's safe, it must be effective. And there's an understanding that the medicines that we use, provided they are registered in the countries that we use them in, these medicines actually meet the quality standards. And if we provide these medicines with the information that the patients need, then hopefully the medicines are used rationally and they will provide the clinical benefits that they are meant to provide. When we look at quality, how do we manage quality and how do we ensure quality in medicines? We look at good manufacturing practices in the manufacturing process. We look at the registration systems in countries. The integrity of the distribution system as medicines move from the manufacturer to central medical stores and then ultimately to the patient. And then through the pharmacovigilance systems as well, we are in a position to sometimes pick up whether we have quality problems with products that are out in the marketplace. When we look at the issue of access to affordable medicines, one of the key policy interventions that many countries have actually introduced are the generic medicines policy, and that has been promoted, and we've heard a lot about generic medicines so far in this particular conference. And what I was trying to explore is around the understanding of quality and whether the issue of generics as well was something that people were willing to use and acceptability of this. The study was undertaken in South Africa. It was undertaken as part of my doctoral research, and it spanned a period of, I think it was from 2005 to 2008. In terms of South Africa itself, South Africa introduced its first national medicines policy in 1996. The country has implemented a generic medicines policy, and interestingly enough, it is at the time of substitution that the pharmacist plays a key role in terms of informing the patient that there are alternatives. There are pricing regulations in the country, and this morning we heard from the Chief Director of the pricing unit, Dr. Anban Pillay. And South Africa has a relatively recognized, well-recognized regulatory authority, the Medicines Control Council, and that council is currently under some review as well. So in terms of the aim of this particular study, what was I looking at? I wanted to compare the actual quality of a few selected medicines from South Africa and measure the actual quality and compare the actual quality to people's perceptions or understandings of quality. And when I talk about people, I was looking at the healthcare providers and the consumers of the medicines. The study design, there was a qualitative component to the study design. The qualitative component used focus group discussions with consumers, and there were 12 of those focus group discussions. And I undertook key informant interviews with healthcare providers. The healthcare providers were selected from both the public and the private sector. They included nurses, doctors, and the pharmacists. And then in terms of the quantitative assessment of the medicines itself, I followed the monographs of the British Pharmacopoeia, and we looked at identity of the active pharmaceutical ingredient, we looked at dissolution testing, and we looked at uniformity of weight. The medicines that were tested were medicines that were readily available in terms of the essential medicines list and all available at primary health care. And these included hydrochlorothiazide, a commonly used medication for treatment of hypertension, amoxicillin, an antibiotic, and then paracetamol, common analgesic. The medicines were actually sourced from the same sorts of places that the consumers in the focus group discussions told me that they got their medicines from. So they were sourced from the private sector, from dispensing doctors in the private sector, from community pharmacies, and also from the state. And I acknowledge my colleagues from the province of KwaZulu-Natal who gave me access to facilities to get some of these medicines from. The study was undertaken in 3 of the major cities of South Africa, and that in itself lends itself to some of the bias of the study as well. I think you can see that, yes. So if we look at the laboratory testings, the medicines were sourced in South Africa, they were taken back to New Zealand, and they were tested in the laboratory in the School of Pharmacy at the University of Otago. And if we look at the results of the laboratory testings, the drugs that we had all passed the tests that they were put through. In terms of the weight, some of the medicines during the transit, when we actually looked at the medicines, there were chips on some of the tablets, and there were a few, one of the capsules were broken. So there could have been an issue around the packaging, and that could have influenced the findings in terms of the weight. But as far as the identity and the dissolution was concerned, those medicines actually met the recommendations in the respective pharmacopoeias. This was the interesting, I must admit, the most interesting part of the study in terms of really getting to understand people's perceptions of quality. I'm trained as a pharmacist. When we look at quality, we look at quality very much from the pharmacological point of view, and the drug must fit in that 93 to 110% availability, etc. When you talk to both healthcare providers and to consumers of medicines and you ask them about quality, what do you understand about this idea of quality of medicine? People found it a little bit difficult, and that's understandable. People use proxy measures to actually express how they understood quality. For the consumers, it was very clear in terms of whether the medicine actually relieved their symptoms and the time it took to relieve that symptom. For the healthcare providers, again, it was around relief of symptoms. And for them, it was also about adverse effects. So for the providers, it was relief of symptoms, timely relief of symptoms, but also few or as little adverse effects as possible. There's a terminology that Zulu-speaking people use, which is called mahala. Mahala means free medicines, and it was interesting when I was with a group of domestic workers, and when I discussed with them the issue of quality, and we talked about medicines from the state, a very firm statement that came out and said that this body does not want mahala medicines. And there was a sense of suspicion around the medicines that were supplied from the state sector. One of the issues that we also checked in terms of quality was the packaging. And unfortunately, I didn't put any of the pictures up, but if you looked at the way medicines were presented from the state sector and also from the dispensing doctors, these were put into plastic packets. They were very, especially from the dispensing doctors, were very, very poorly labeled, often just hand labeled. The medicines that came from the state sector were often also in plastic packets, but had a better labeling on them. And then the ones that came from the community pharmacies were often in boxes or in polypops with good quality labeling, I suppose. And that seemed to influence the way people understood quality in terms of the presentation as well. But this issue of free medicines, I mean, it's a strange thing to think about, but people were saying that if I'm getting this medicine, there was a belief that when you paid for something, there was value in that. Because if things come for free, why am I getting it for free? So there was this sort of suspicion around free medicines that were provided through the state sector. In terms of the generic medicines, there was wider acceptability of generics amongst the healthcare providers. But what was important to the prescribers especially was the name of the manufacturer. And so if they had prior experience with the product, and if they knew that the product came from a reputable company, and if they looked at the brand of the product, there was more of a willingness to actually accept that particular product. So there, the reputation played an important role. There was an interesting, and this came from the consumers as well, where in the city of Johannesburg, people refer to counterfeit products as Fong Kong. So if they had the sense that the medicines were coming from the East, and then they were questioning the quality because they said this could potentially be Fong Kong. In terms of acceptability of generic medicines amongst consumers, where price mattered and where patients were actually taking chronic medicines for a longer period of time, there was a greater acceptability for generic medicines. And then in terms of selection, and if we go back to the generic medicines policy in South Africa, the policy is at the time of dispensing, the pharmacist can actually substitute at the point of dispensing. When you spoke to the consumers, there was a greater reliance on the prescriber. So when it came to over-the-counter medicines like the paracetamol, which was bought over the counter, people would go for the brand name that they knew, which was Panado in South Africa, the originator's brand. But when it came to prescription medicines, there was more reliance on what the prescriber was actually saying. So there would be a willingness to substitute provided they got the permission from the prescriber. So that just summarizes what I've actually been saying. And I think what was key in terms of the consumers as well was that there was a sense of confusion around quality of care. People were transferring their experiences in the public sector facilities and largely some of their negative experiences to the services that they received and the products that they actually received from that particular sector. So, the fact that you sit down with a doctor and you can have a conversation with the doctor, or you go into a community pharmacy where perhaps there's a bench there or a chair to sit on and you have some time, people take time to talk to you, tell you a little bit about your product. And there was a sense that when you go to the public sector facilities, you were getting none of that. So people were transferring their experiences with poor quality of medicines. The lesson I guess we learned from this is, when we look at quality of medicines, again, when we test for quality, when we assess quality, we use the pharmacological sciences, we use the pharmaceutical sciences, and that is underpinned by a biomedical framework. But when you are talking to people and when you're looking at their experiences and their behaviors, they are actually informed by the social and cultural context in which they find themselves in. And we need to marry these two, because we talk about the medicine being of good quality. Yes, the generic meets its standard, it's registered, all of that. But the person is not going to use it because there are other proxy measures that they are using to say to themselves. So their values, their understandings, and are we adequately addressing that when we provide medicines to people? And I think there's a large responsibility for the generic manufacturers to actually take on board some of their responsibilities in terms of the information that they provide, to look at their marketing campaigns, etc. I didn't discuss this in the study itself, but one of the things we did with the public sector facilities was speaking to the chief pharmacists at the provincial depots, and they found that if they experienced quality problems with a product, often, if that was from a generic manufacturer and often a local producer, very rarely would they get feedback. But if it was an innovator brand company, and if there was a problem with the packaging or there was a problem with the product, there was a quick turnaround time and quick response to dealing with that. So again, it's about how these companies actually look after their product once it's in the marketplace. And some of the recommendations then would be for the regulator to proactively manage product complaints. When we get, there were a series of complaints from especially from the public sector pharmacists when they approached the Medicines Control Council around a quality problem, and that could be around labeling, leaking bottles, etc. Very often there never was feedback. So if quality is important and if the regulator is there to ensure quality throughout the distribution system and throughout the pharmaceutical system, then make sure you have something in place to address the issues when they come to you, even if the problem sounds small. When we look at implementation of national medicines policies, we talk about indicator studies, baseline studies, time series, etc. But we are dealing with people that are going to use these medicines. We need to understand them, and we need to put time and effort into understanding them. And I think this morning we heard from Kathleen Holloway some of the issues we face in the pharmaceutical sector around pharmaceutical public health and some of our tertiary institutions. Are we bringing in methodologies that are going to allow us to actually undertake studies like this? We need to buy from the social sciences or bring in from the social sciences, and we need to be marrying. So you've got to have these multidisciplinary teams that go out, because it's not just about undertaking an indicator study and telling us that there's a problem. We need to understand why we have that problem. And in terms of generic substitution, it's important that we actually manage the demand. We substitute the medicine. We need to make sure that we are informing people that these drugs are registered in the country, that you have a regulatory authority that you can actually trust. These are the sorts of tests that are undertaken, and we are substituting for these reasons. And I think that needs to be a proactive process that the country must undertake. There's further details in my poster, in poster 210, and I'd like to thank you for paying attention.
Thank you, Aarti. As before, we're going to allow for a few clarifying questions, and the microphone will be brought over here. Thank you. Well, we have another one over here too, but either one wants to go first. Sir.
Just a quick question.
Okay, we have three hands up. 1, 2, and 3, 4. Let's make them quick, because we're going to have time at the end as well.
Did you find any, with patients, did you find any difference for those suffering acute or chronic symptoms, or symptomatic versus asymptomatic symptoms?
Well, the difference was the ones with chronic illnesses that were taking generic medicines, there was just wider acceptability of generics in that sense. That was the only difference that I actually found here.
Okay, I'm Godfrey Bosa from Makerere University, College of Health Sciences. Now, other than the dissolution and the weight, are those enough to say that these products were of quality?
We tested with the Fourier transfer, FTIR, infrared spectroscopy, for the active ingredient as well.
Thank you for your presentation. My name is Helen Daje from the National Drug Authority in Uganda. And yes, I wanted to know, you've looked at the perspective of the patient and of the health workers. What about the perspective of quality from the regulator's perspective? I mean, from the regulator's angle. And trying to collect them with what you found.
I'm amongst friends, so I suppose I could say that. I contacted our Medicines Control Council, asked them if we have poor quality medicines in South Africa, and I was told we have very good quality medicines in the country.
Hi, my name is Darash Desai from Boston University. Two quick questions. One, do you know the specifics of the type of dissolution that was done?
Sorry?
The type of dissolution that was done, do you know the specifics?
For the amoxicillin, I used the USP recommendations. I think it was the paddle method, and then there were the basket methods, yeah.
Okay.
So I just went for the monographs that were listed for the drugs.
Right. Okay. And then, did you actually, for the focus groups, did you look at the socioeconomic status of the individuals in the focus group? And okay.
What I tried to do was to actually look at lower and middle income. And again, they use proxy measures. I looked at whether people were formally employed or informally employed, and looked at what the sort of income was and gender. The groups were kept as males and females separate. I also looked at whether they were formally employed, informally employed, level of education, etc.
Did you see any biases in the different groups, or was it generally the same?
Yes, the main bias was that I only studied the urban settings, and I relied on key informants, especially for getting people in from the informal sector, so that could have influenced the selection of the participants. Yeah.
Okay. Thank you very much. So we are going to have time at the end of all 4 sessions for a fuller discussion of questions from the audience and, in fact, questions from the panelists themselves. At this time, however, we're going to go ahead and break for 20 minutes for tea and coffee, and we very much look forward to seeing you all back here in 20 minutes when we're going to start with the second 2 presentations, also on quality assurance for essential medicines, as well as interventions to improve medication safety. We're looking forward to those. And if you want to talk a friend into joining you so we can fill up a few more seats, that would be welcomed as well. So at this point, we're going to conclude the first part of our session and see you in 20 minutes, and then my colleague, Andrea Mont, is going to take over from there. Do you want to say anything further?
Just want to say that means by my clock, 4:20. Okay, so we'll start again 4:20.
Okay, thank you again.
Lower and middle income countries. I hope you're refreshed by your cup of tea or coffee. Now, what we're going to do in the second part of the session, we're going to hear 2 further presentations, and then again with your clarifying questions for those 2 speakers, and then we're going to have the panel and yourselves working together to answer the key questions we've been set for our session to ensure that there are outcomes the rapporteurs can take to the rest of the delegation. Okay, so our first speaker now is Dr. Joelle Daviaud, who is a pharmacist and works with the Global Fund in Geneva, and she's going to talk to us about her study of quality assurance for essential medicines other than ARVs, antimalarials, and anti-TB medicines. Thank you, Joelle.
Yeah. Good afternoon, everybody, and I would like, first of all, to thank the ECM committee to invite me to present our result about the study on quality assurance for essential medicines, which are not the ARV, TB, and malaria, but all other medicines. That's right. Mm-hmm. So, just to brief you a little bit about what is a Global Fund. The Global Fund is a financial institution, and we fund programs developed by country and implemented by the country and the procurement of the medicines, when the program include procurement of medicines, are performed by the principal recipient at country level. It's not the Global Fund itself which are the responsible of the procurement of drugs, but it's a principal recipient at country level. And we have set a lot of principles to request our principal recipient to procure a product, which should be the first criteria that the product should be of a sure quality, and the procurement should be conducted through transparent and competitive process, and in a clear adherence with the national and international law. And of course, we request the principal recipient to select the product at the lower price possible when there are multiple choice at the same level of quality of medicines. The fund used for the procurement of product are almost 20% of the fund used by the country are dedicated to the procurement of medicines, and 17% are dedicated for other health products, which means that it's a huge amount of money when you consider that for the time being, the Global Fund pledged for $20 billion of US dollar. So almost 20% is a huge amount of money. So therefore, it's quite critical that the Global Fund issue a quality assurance policy to help the PR to select in an appropriate manner the product to be purchased with the Global Fund resources. The Global Fund issued the first policy in 2002, and this policy has been revised many times since this first QA policy. And the last revision occurred in 2009. And since this 2009 policy, we have had also other amendments to allow the purchase of appropriate medicines. We have in this policy, we define clinical criteria, quality criteria, and we also request PR to monitor the quality of the product from the entry of the product at country level until the end user, and which is not limited to the quality control in the laboratory, but it includes also random quality control testing. The main focus of today is to discuss about quality criteria. The first requirement for the Global Fund is to request that all the medicines purchased with the Global Fund resources be authorized for use in the recipient country. We have additional stringent requirements for ARV, TB, malaria, meaning that for all of these products, we request the principal recipient to select products which are either WHO pre-qualified or SRA authorized. And when there are no other enough products available on the market, they have a third criteria which we name ERP product, meaning it's a product which has been reviewed through by the expert review panel, and who made a risk-benefit assessment to determine if we can use or not this type of product. But since 2008, when we reviewed the QA policy in general and we set up these strong requirements for ARV, TB, and malaria, we have been asked also by the committee to really think how we can develop stronger criteria for other medicines than ARV, TB, and malaria. On this slide, you can see that for all these medicines, other than ARV, TB, and malaria, we have only two strong requirements: that the product be registered or authorized by the country of use, and also that the procurement be done in accordance with all the principles defined in the WHO Model Quality Assurance System for procurement agency, which include a lot of principles from the selection of product until the distribution of the product to the end users. But for other products, you see that we request stronger criteria, WHO, SRA authorized, or EAP. The Global Fund monitor the compliance of the purchase with these quality criteria. And we request the grant recipient to provide reports on quarterly basis to know what they have purchased, but also to fill what we name our database, which is the PQR, Price, Quality and Reporting Database, in which the PR needs to report all their purchase and indicate which type of product, quantity, the manufacturer, manufacturing site, and all this important information which allow us after that to analyze this data and to identify if the product has been purchased according to our QA policy, yes or not. And it's a condition for the PR to receive the next disbursement. So before each disbursement, we review this data and we accept to disburse again only if they have followed our QA policy. And in fact, we after analysis of this data, now at the end of 2011, we have less than 1% of the purchase reported which are not compliant with our QA policy, which is very few purchase in fact, and this purchase, we follow up with the PR and we require them to justify. And we can also ask the PR to reimburse the Global Fund if they have purchased products which are not in compliance. So it's a very strong and strict policy. But again, all of these analyses are done for ARV, TB, and malaria, but not enough for other products, which, as for the time being, they do not report non-ARV, TB, and malaria product on this database. One of the consequences of the strong QA requirements for ARV, TB, and malaria is that you can see that in red, it's a product, ARV product, which have been purchased for more than $500 million since 2009, 10, and 11. And in fact, 98% are products which are pre-qualified by WHO or SRA authorized. Almost 100%, which is enormous compared to 4 years ago when this ratio was around 66%. Why? It's because we have more and more product available today in in the market which comply with these strong requirements. For TB products, this ratio is of 71%. And for malaria, it's almost 90% for products which are pre-qualified or SRA authorized. So step by step, even for malaria and TB, we have more and more product purchased and which are of really assured quality. But again, we have not enough data regarding the other product, which represent almost 10% of the product which are purchased with the Global Fund fund. And we conduct a study to identify what was the quality status of the product purchased with the Global Fund money. And the aim of this study was to identify areas for improvement and to inform policy development. So we use different steps. We have different phases in this study. The first phase was a desk review and a survey. We review publication and report published in the public domain, and we develop a survey which have been made through questionnaire, which have been sent to donors, to procurement agents, and to implementers. And we have received 27 answers to the 53 questionnaires sent. In addition, we also conducted five surveys in 5 countries, which are Armenia, Burkina Faso, Cambodia, Nepal, and Nicaragua. We have selected this country based on the diversity of geographical situation of this country, but also and mainly based on the fact that in each of these countries, the principal recipient was different, meaning that in some countries it's a Ministry of Health, in other countries it could be the UNDP, a UN agency, in other countries. So based on the different approach from these different principal recipients, which is very important for us. And when we went to this country, we met with important people for us, which are representative of facilities at different level. We met also with the regulatory authority, with the local manufacturer, with, of course, the recipient of the Global Fund grants, with WHO country office, with disease program managers, and also procurement agents when they were at the country level. Unfortunately, the main outcome of this study, the desk review, the survey, and also the field study, came to the conclusion that the global pharmaceutical market for non-ATM medicine is at a high risk, really. And we presume this, but it's really a reality through these 3 steps of evaluation. We have, first of all, very poor regulation, which means that there are most of the products which have been purchased for the time being and used at a country level are really poor regulated, not of a sure quality, which put patients at risk. We thought that there are a predominance of price in purchase procedure and which are not linked with a clear quality requirement, so price before quality. And in addition to that, specifically for the Global Fund, we have made a survey to know which type of product have been purchased with our money. And in fact, we detect that 80% of these products are anti-infective products in 2000, and this study has been done in 2010, and which are life-saving products also. So it's really concerning to realize the poor quality of this product at country level. So why what are the challenges with the quality of this product? In fact, we identified there are 3 main actors for us, at least for the Global Fund, meaning that we, as a donor, we request the product to be at least registered or authorized by the National Regulatory Authority, and meaning that which should be the legally responsible people in the country of use. But unfortunately, a lot of NRA has a weak capacity to assess for the assessment of dossier and for the follow-up of the quality of the product at country level. In addition, all of this, so the donor, which rely on capacity of the NRA, and the donor, most of the donors have no quality assurance policy, no specific requirements for the purchase of non-ATM product, which means that all this activity is delegated to procurement agent or to grant recipients with no clue about, not clue, but no requirement and strict requirements. In fact, we have also to consider that the market is a small market, in fact, and with no clear quality criteria. And to answer to this type of lack of clear quality criteria, we identify that in many countries by the National Regulatory Authority or the procurement agent or different level at the country, they use and they overuse quality control testing in laboratory, which does not mean that the products are of a sure quality. We constate also that there is a very complex procurement channel at country. So all of these steps mean that the procurement of this product are very difficult. So we identify some weaknesses at regulatory level, not only in a developing country, but also in a developed country. And I have no time to go through all of this, but it's on the poster, and you have also the presentation. But it's for the assessment of the manufacturing site. It could be also regarding the authorization of medicine of use, because the authority have not access to the acceptable level of information, and also regarding the post-marketing surveillance, there are poor capacity for medicines control in many, many countries. And in a developed country, there is a resource and independent technical expertise for global pharmaceutical QA, but it's become increasingly scarce. And we also know that the products which are registered for export as registered with not the same level of stringency than the products which are registered for the use in developed country, which is a big concern also. We have also highlighted the weaknesses at the procurement level, and for the selection of the product, there are poor knowledge and understanding of norm and standard generally. There is difficult access on technical references, and there are poor quality of information submitted by the supplier. And in terms of quality control testing at country level, not only at country level, but everywhere, yes, at country level, of course, there is difficulty to confirm the identity of the product which have been supplied by the supplier in the country. We do not know even if we request a product to be WHO pre-qualified. We have not enough traceability when the product arrives at country level to be sure that it's exactly this product which arrived. And there are lack of internationally recognized standards, and sometimes even we have the laboratory could not access to the manufacturer's specification. So during this survey, we met with a lot of different stakeholders, and all stakeholder requests for a global solution and to an harmonized solution for defining a set of criteria for this type of product. We could not accept there are double standards of product at the country level. Some are registered by stringent regulatory authorities, some other are not registered at all and just authorized, sometimes through fast-track procedure, but sometimes they are just authorized with no information at country level. We need also to include resource mobilization to promote quality assurance at any country. So, based on this request from the different stakeholders, based on the conclusion of our first survey at country level and through questionnaire and through the desk review, we were already convinced, but we decided to convene a joint meeting with WHO and Global Fund and to invite our main partners to work all together to define a set of quality criteria for this type of product. And end of August this year, we have had this meeting with 16 international organizations, and there were donors, there were implementers, procurement agents, and we all worked together during 2 days and share our practices and our concerns, and maybe for some of us, we also share some practical approaches. And one of the discussions we have had during this 2-day meeting is which standard to apply to which product. Can we consider all the essential list of medicine as a whole, or do we need to prioritize within this essential list of medicines some type of product which are more important than other, because the impact of non-quality of those products, like for antibiotics, could have a huge impact on the life of the people. So we discussed a stepwise approach and a risk-based approach, and we took all the 5 requirements that we have today for ATM product, and we discussed a little bit which type of criteria we can apply to which type of product. And the conclusion, I have no time to go in depth, but again, it's on my poster. And at the conclusion of our QA and joint meeting was that we all call for a common approach with harmonized criteria, and to allow efficient use of scarce technical resources, to have a maximum market impact, because even if it's limited, if we have all together the same set of criteria, we may have an impact, and we may give a specific message, not only to country, but also to manufacturer to produce product of assured quality. And we need to have to avoid any confusion with the double standard at country level, which is not acceptable. We also want to define specific criteria when a risk classification by WHO is finalized. So we need to consider medicines in each class and what are the associated risks, and also define appropriate mechanisms to mitigate this risk in implementing specific quality criteria. But of course, it is critical for all of us to keep the recipient country and the NRA of the recipient country in the definition of all of this work. So the responsibility of the NRA remains intact, and we really want to involve them. So the next steps now is that we continue, donor and procurement agency will continue to work towards common quality requirements for non-ATM medicines. The risk categorization of essential medicines by WHO should be done in 2012. But in the meantime, we also work a lot, discuss a lot about what could be the impact of the procurement agent, international procurement agent, but also national procurement agent. And as you may know, with this model quality assurance system, which have been developed since 2003, are used today by a large number of people. And all of us, the partners who participate to this meeting in August, have developed their own tool based on this document. But we realize that all of us define different indicators, and we have decided as a to set up a working group to define a common tool based on this MQS and we would like to have this common tool finalized by the September 2012 to propose this new tool to the WHO, for WHO to endorse this tool and to update this MQS. So it's the next step for 2012, taking into account that we will also organize additional meetings involving the country and the NRA of the country during the next year also. Thank you for your attention, and I can answer to questions.
Thank you very much, Joelle. It was a very comprehensive description of the QA policy and how to develop it in a new area. Are there any questions from the floor? From the floor, just clarifying. Yeah, thank you.
Joelle, I didn't hear mention of the Pharmaceutical Inspection Cooperation Scheme. Is there a role for them at all?
Okay, so the PIC scheme, inspectorate, we recognize the certificate of GMP certificate issued by all of this body for when they assess the manufacturing site of ARV, TB, and malaria. But for the time being, it's not yet a requirement for other type of products. So definitely, we will consider the GMP, GMP manufacturing site certification when we will develop this set of criteria, and probably this PIC scheme member will have a huge role to play in this area.
Thank you. In February in New York, FDA Commissioner Peggy Hamburg chaired a meeting of various global drug regulators, including representatives from EMA, MHRA, Nigeria, other countries. And the theory was that global regulators needed to cooperate more to harmonize quality standards. I noticed on your list of groups that you're working with that neither the FDA nor any EMA member regulators were on that list. Is that something you'd pursue, or were they left off for a reason?
No, during this meeting we discussed a lot about all this regional approach and all of this consortium from the different NRA, and we are using and we would like to use and to work as much as possible with all the group of NRA. We are working also regularly, and we recognize also, of course, all US FDA conclusion when they register product, the EMEA, and all the regulatory authority of member of ICH are absolutely recognized. But we would like also to strengthen and to push country to strengthen their own regulatory authority, and maybe to consider also regional approaches, and not only for, because we know that the time for each regulatory authority to have all these 6 main functions fully functional will take a lot of time, and we will more in favor to consider regional approach also. But we cannot decide for the country and for the region. It's the work that we need to do, and not the Global Fund, because we are not a technical agency, but we are working with the WHO and other partners to push in this direction.
Thank you. Are there any other questions there? Or we might move on then, I think. Thank you. So now it's my great pleasure to welcome Wimon Anansakunwatt,
yes,
from Thailand. She's from the pharmacy department at Siraraj Hospital and Mahidol University in Bangkok. Thank you.
Good afternoon, ladies and gentlemen. Thank you for your attending this session. I would like to thank ICM Committee and WHO Regional Office to support me in attendance for this conference. You are falling from the macro level to the micro level now, because this study is done in a hospital, only one hospital. So it is the micro level. The study is interventions to improve medication safety in a university hospital in Thailand. The problem statement, as we know, adverse drug events were found a major complication of hospitalized patients, and most of them were preventable. So several interventions were implemented in Siriraj Hospital during the past 10 years. For example, the medication error reporting system, the drug information service and poison control center, adverse drug reaction monitoring, staff education program, and patient education program. Because we believe that if we implement these interventions, we can bring our patient more safety in medication use. But during the past 10 years, there was no study to compare and conclude the success factors of these interventions. One background that I should inform you is that these interventions were initiated when the hospital was enrolled into the hospital accreditation process. The objective is to study common success factor, and the design is observational descriptive study. The hospital has 2,300 beds, tertiary care, teaching hospital, and under Mahidol University, Thailand. The method that we use is the review of the reports and minutes of team meeting and discussion with key persons of each team who invented their intervention. The outcome measures. We collect the number of medication error reports, collect the adverse drug reaction prevention reports, the phone calls to drug information services and poison control center, the score of tests in education programs, and from the staff interviews, we collect the factors that influence success of these interventions. First of all, I would like to show you the drug information services and poison control center. From the beginning in 2001, the data collection is not complete because we have only one pharmacist in that center, and she had so many things to do. So I'm not sure that the number is correct or not. So we can collect from 2004. From 2001 to 2004, the number of calls is about 1,000 per year and gradually increasing. But after the intervention, we changed the services from 8 hours to 24 hours in 2007 and included toxicologists as consultants and provided staff education programs. And these 3 interventions increased the consultation by phone call from 2,000 questions per year to 20,000 questions per year. Do you want to know why so many questions they ask? What do they want to know? The highest bar, can I point it? This one? Yes. The highest bar, you can count here. Number 5. The dosage and administration. They want to know what is the correct dose and what is the indication that the prescriber prescribed. And number 2 is the therapeutic use and efficacy. This is because we are teaching hospital. We have young staff, young residents, young nurses, and also young pharmacists. Sometimes they don't know about the new drugs, don't know much about it. So they ask drug information service. The third ranking is the compatibility and stability. This one, the purple one, from nurses. Most of them are nurses. They want to know how to mix the drug with the solvent or the diluent and how to administer the drug correctly. The fourth is the availability of drug in the hospital. And the fifth is the adverse drug reaction question. So the next intervention is adverse drug reaction monitoring program. We use the computerized alert in pharmacy prescription processing by printing alert notes for nurses and pharmacists. And we promoted asking patients a prime question for their own known allergy. The result, after we use this intervention, the computer will print out the drug name of the known allergy out, and pharmacists can see from the sticker that printed out. And this sticker will be sent to the nurse station. The name of the drug will put on the pink label of the patient chart, and the wristband will be changed from white color to red color to alert all personnel of this patient's drug allergy. After implemented this intervention, we could prevent more repeated known allergy cases from 152 cases per year to 3,139 cases per year. The next intervention is medication error reporting. The reporting increased significantly after changing from manually reporting to online reporting, and we're gathering reports from nursing department and pharmacy department also. Some report is anonymous. We don't know who make the error, but we want to know the cause or the incident. So they are happy to key online more than give the paper to the risk management office. The medication error incidents were communicated to staff through monthly newsletter like this, which provide 2,000 copies per month to prescribers, nurses, and pharmacists to warn that the incident had happened already. And some errors were analyzed and prevention strategies were used, such as this picture. If the packaging look alike and they confused of the strength of the drug by the packaging, we enforced the pharmaceutical company to put the colorful strip on the box of one size or one strength that will identify easily. The next intervention is staff education program, which is very important. We found that our staff improved their knowledge significantly from pre-test to post-test after training of the high alert drugs and drug administration training. In high alert drugs training of 312 staffs, the pre-test score was only 68.1%, but the post-test was 88.7%. In drug administration training, the pre-test score was 63.5%, but the post-test was 81.8% from 244 staffs. I think if they know more, they have more knowledge, they will treat their patient correctly and the patient will get more safety. The last intervention is the patient education program. After empowering patients to use their medication correctly and monitor themselves by patient education program, we found that their knowledge increased significantly both in transplantation clinic and anticoagulation clinic. As you can see, from 29 to 55% in transplantation clinic, 70 patients, and from 58.6 to 93.3, 1,502 patients in anticoagulation clinic. The criteria for enrollment of patients to the program were first time receiving high alert medicine, such as warfarin, immunosuppressive, anti-cancer. The second criterion is the laboratory results were not as good as expected. So we enroll that patient to see pharmacist. And pharmacists give them more education. And the third criterion is the patient had other drug-related problem, for example, drug-drug interaction that need to see pharmacist. Another part of the study is staff interview. From staff interview and minute and reports review, we found that some terms were used repeatedly. They were standard, quality, accreditation survey, multidisciplinary team, computer program, counseling, and education. The most interesting finding was key persons of each intervention worked very hard after office hours to improve their interventions. I think it is worldwide. Need work harder. We concluded that the common success factors of the interventions to improve medication safety in a hospital were accreditation from external organizations. This is a very strong drive in my country because every hospital administrators want to certify their hospital that their hospital has quality, high quality. So it is a competitive process. Another factor is the multidisciplinary team approach, which includes prescribers, nurses, and pharmacists. The third factor is the using information technology properly or effectively. Another one is patient participation. And the last one is the devoted personnel. This will enhance the strength of intervention. So we recommended to strengthen these success factors in interventions to improve medication safety in hospital level. We also suggested that the economic outcome studies of these interventions should be conducted. Thank you so much for your attention. Your comments are very welcome. Thank you.
Thank you very much, Wimon, and particularly thank you for a wonderfully concise presentation with all that detail contained in a very succinct way. Now, are there any questions to clarify for Wimon at the moment?
Thank you very much. My name is Ibrahim from Nigeria. That's a very brilliant interventions that you did. I wanted to make some clarifications. The call for the DIS, was it toll-free?
Yes.
Okay, that is very good.
Free of charge.
Because that is very important for them to feel free to call at any time. Then secondly, I wanted to find out the pre and post education intervention. How long was it between the pre and the post? Was it a month or 2 months or how long?
For patient?
For the staff.
For staff?
Yeah.
Pre-test start before we give lecture and post-test after finish the lecture.
Okay, then how do you
immediately.
sustain that, that knowledge, improved knowledge? Because probably after a month, they may have, had lost reduction in their knowledge. You want to train them again and things like that. Probably that would be a good point for more research.
Yes, I understand. So we have the episode 1 and episode 2 and part 1, part 2, and repeat some part and add more information each class. Thank you.
I noticed you, just a comment from me or question really. You said that one of the success factors was the devotion of the staff to spend time doing this work and improving their interventions. And I thought that was very interesting. It must be just my country, Australia, where that would be considered something they'd be whinging about, be complaining about, that they had to spend the time. But I noticed that in your fine hospital, they thought that was a sign of how important it was. Right? Is that the way it goes in Thailand?
After working hard, we try to make the administrators understand the benefit of adding more pharmacists into the system. So my hospital have 199 pharmacists now. Too many.
That's good. Thank you. Any other questions for Wimon? Okay. Well, so thank you very much. Now, I've got one more question from the floor, which is directly for, or clarification question for you, Aarti, if I may ask, just a question for you from the floor. Thanks for the presentation on quality medicines in South Africa. Now, you remember Aarti's study which used the in vitro testing of dissolution, right? And identity. Anyway, the questioner asks, did the study look at other pertinent issues of medicine's quality, such as bioavailability or other pharmacological parameters? And that would be, and in particular, did that occur for paracetamol?
Thank you for the question. What the study did was looked at
bioequivalence in terms of using the dissolution testing, but the main purpose of the study was really to look at perceptions of quality against the actual quality. So we just went for those 3 tests that were there. It wasn't really to go deep into the actual quality of the medicines. And those tests were done for all 3 drugs that were actually assessed.
So the answer is, it was limited testing was done for all of the 3 subjects. Thank you. Well, now, what I want to do now, we've got to do a bit of work, all of us now, together, to make sure that we've got some good content for our rapporteurs to take to the to wrap up the session with. And in particular, we want to focus our questions for the panel and the panel's thoughts as well on 3 issues that we've been asked to address from each of our sessions. And the first one is about what have we learned, you know, what are the 5 important things we might have learned. The second area is on the 5 important recommendations for policy that might come out of what we've heard today. And the final one is to think about 3 research questions that might have come out that are urgently needed to follow up on the work today. We've heard some quite varied papers methodologically and also, as Wimon pointed out, in terms of macro or micro. So very different papers all dealing with various aspects of quality assurance and the kind of ways of understanding how to improve quality. Okay, so I wonder who'd like to start the ball rolling from the audience or from the panel? Anyone from the audience want to start? Or? Okay, we've got a couple of takers. Okay, yeah, that's all right. I just thought it was closer. Can we ask for you? And would you mind, please do say your name, and I apologise because I forgot to say mine, but I'm Andrea Mand from Sydney, Australia. Okay.
I'm Aukje Mantel, Utrecht University, the Netherlands. I would like to follow up on the question that was posed previously, because I had the same remark as to the presentation by Ambrose. So is it really, when you look at the indicators, especially the outcome indicators, is it really quick and robust? Because many of those, especially when it comes to ADR-related hospitalizations, etc., I'm not sure it is that easy. And even maybe variations in summary of product characteristics related to safety. I think if you would call EMA and ask how many variations did you have this year, I don't think they can give you the answer right away. And they have an automated system but still can't do it. So I was wondering, especially for those outcome indicators, is it really quick and easily measurable, and are we going to do that every year, or what's your view on that?
Well, thank you very much. Now, you have to appreciate the outcome and impact indicators, what they are meant for. You have a system, pharmacovigilance system. You now want to measure what effect, what changes it is making. It's usually on a long term. It's, this is not a quick thing, what you do, today, and we expect the answer tomorrow. No. So that you find that the measures there require surveys and time to be able to get them. But they have, the utility is this. You want to go to maybe advocate for pharmacovigilance. You must be able to tell them what pharmacovigilance is doing. How many deaths are you preventing? Medicine-related deaths are you preventing, for instance? What are the signals being generated or, over time? You must have some of these measures over time. So it is not a quick fix. No, not at all, not a quick fix. It's something you do over time, And you find that they are more difficult to measure. So they may even require surveys. And looking at the nature, the settings determine, what outcome or impact indicators you're measuring. For hospital settings and all that, you may be able to measure the, hospital, in terms of hospitalization, days, you are going to save from applying appropriate pharmacovigilance measures and all that. Nationally, you may be able to take samples of hospitals within the country and do a national survey, and to obtain the indices. So it depends on what you are doing. As you know, the indicators themselves drive data collection. So when the indicators are in place, people will know they have to, get this data ready so as to calculate the indicators.
Yeah, if I could, since we're on the topic, I just want to add that the area of indicators for pharmacovigilance systems performance really is a critical one, not only for program action, but a research need. That's my own perspective. And that indicators for performance should meet certain criteria, having, for example, validation, feasibility, which was asked, the ability to differentiate between good and perhaps not so good performance. And there's at least one poster out, I believe it's number 513, that is by Jude Wakoki and actually myself, and we looked at one indicator, which was time to regulatory action, how much time elapsed between a signal and an alert from a stringent regulatory authority to when various national regulatory authorities picked up on that and did some action. And if I can also add to that, and Ambrose and I had a little side discussion here, is the Strengthening Pharmaceutical Systems program has put some time and effort into developing an indicator-based pharmacovigilance assessment tool, which is publicly available and also available for consideration of harmonization with the work that we heard about from Ambrose and colleagues at WHO. So I would put that on an agenda for potential program action and research needs.
Thanks, Andy Gray, South Africa. A follow-on to that one, Ambrose. For some of the process indicators that are easier to collect, I wondered if there was any consideration yet of targets that might be set for those. So, for example, the number of ADR reports per 100,000 population per year. Is there a level which constitutes acceptable PCV performance in a country?
Well, thank you very much for that question. You see, the first thing is to have the indicators. I was involved with the inroad indicators, and after it was set up, I developed the targets. That is the number of drugs, average number of drugs for a given setting this was in Nigeria. I'm sure, that's available, you can see. So the first thing, you have to set the indicators, make sure it's acceptable, and then the performance targets you can now work towards by developing standards. What is the standard of care? What do you think is appropriate? So I don't have that now. We've not reached that stage. I think that should be the next step when you have the indicators in place.
Libby Ruffhead from the University of South Australia. I just wanted to reinforce that point about the importance of indicators. It's 20 years, I think, since Australia first developed its indicators for quality use of medicines. And we had a number that were kind of aspirational indicators. Certainly we couldn't measure them at the time. And I think there might even be a couple we still can't measure. But what they were very good at doing was keeping the things that we were striving for on the agenda. And I don't think that should be lost sight of. And I think that's one of the really important things about the outcome indicators in particular in this set for the pharmacovigilance systems.
I think there was somebody right up the back, was there?
Yes.
No? Maybe not. So then here, here we go.
Thank you all for the wonderful presentations. My name is Francis Kalemera. I'm a pharmacist, coordinator of the Therapeutics Information and Pharmacovigilance Center in Namibia. My question goes to I can't read the name from far away, but it's got to do with Global Fund. I was impressed by the quality assurance that you talked about when dealing with medicines that are different from the antiretrovirals, the TB and malaria medicines, especially because now we are facing an increased measure of other diseases, and, which is an issue that we have recognized even in this ICM. I'm thinking about the resource-limited countries. Because if you, for example, do take medicines through quality assurance, and then maybe they pass the test, and then they are bought by the country, probably in bulk, because there is advantage in buying bulk, and then now we go to the stage of storage of medicines. And the countries do have challenges in their storage systems, where probably medicines might be challenged with probably accelerated decomposition, and then we get back to the problem of quality. I'm thinking about enforcing post-marketing surveillance in the country systems, so that in some countries where temperatures can be really high, it might be important to have steady post-marketing surveillance standard which keep going on to ensure that these medicines are really safe to use or effective to use. The other thing, apart from that, is to maybe enforce a kind of like purchasing mechanism that will limit the purchasing of medicines, the bulk, but maybe through contracts establishment between the manufacturers, so that when a deal is made, you know the manufacturers are happy that they are going to provide a particular quantity, but the expiry date of the medicine will not, get into the stores of these people, because I think that is one of the challenges that are faced. Thank you.
Okay, thank you for your question. I think it's a very important question, and we need absolutely to answer to this question, and it was the reason why we have requested country to perform quality monitoring of all drugs, not only ARV, TB and malaria, but specifically for all other type of medicines, all along the supply chain, meaning when they receive the product at country level until the use of this product by the users, and to randomly sample product to be sure that the end user receives the product of assured quality. For the time being, and for that, we request our principal recipient to establish a testing plan and sampling plan, and to use a quality laboratory for quality control, which are either WHO pre-qualified laboratory or at the minimum ISO certified, 17025 certified laboratory, to be sure that the quality control testing at the country level, or when they send to in another country, are performed by appropriate laboratory who can easily detect if there is something wrong with the product. We also request, as much as possible, our principal recipient to split their purchase, meaning that to have an appropriate forecast, because it's important for the manufacturer to plan in advance what could be the volume of product to be delivered at the country level, because they need to plan their production, and also to plan their purchase of API in advance. So we request our PR to forecast appropriately, to perform procurement of their product in advance, but to receive the product at a different time during the year or during the 2 years. The question, and just to avoid that the same product are stored in a storage condition which are not always appropriate. The question is that our principal recipient at country level answered to us that it's the cost in receiving the product at different time during the implementation of their grants is most costly because they have to distribute at a different time, which is more costly. However, I think that the Global Fund can cover this amount of money, provided the fact that the appropriate forecast has been done, and provided the fact that all the distribution channel is well monitored also to be sure that everything has been properly planned in advance and installed. We also can finance some improvement of the storage room, of the warehouse, if it's requested by the country. But again, sometimes it's not always easy for a country to recognize some of weaknesses that they consider as a huge weaknesses. Of course there are, but it's better to recognize and to request some technical assistance, some funds to improve the system. And so it's capacity building, I would say. And we need to continue to work very closely with the country to fix all of this problem. And fortunately, at least for ARV, TB, and malaria, the WHO performed some evaluation of the quality of the product, which have been sampled at different levels in different countries. And you can see that for all ARV and malaria studies which have been published by WHO, all products which are pre-qualified are still of assured quality even after a few months at country level. And why? It's because when WHO pre-qualified a product, they request stability study at the most difficult, in the most difficult situation, meaning it's under phase 4, meaning that it's high temperature, high pressure, and everything. So, and we have not the same data for other type of products. So that is the reason why we rely on some references when they have evaluated that medicines.
Thank you. Peter Pitts, USA. One of the problems with pharmacovigilance is having the adverse event report go up the chain beyond the physician. Obviously, a patient will call a doctor. The doctor's primary goal is to help the patient solve his or her problem. It rarely reaches then beyond the physician's office to a regulatory body for a report. So from a data collection policy perspective, I would ask, could we put together a best practices for countries to educate patients and pharmacists and physicians to report up the line? Obviously, this impacts the signals-to-noise question, which is another debate, to help increase the data collected. I think one of the reasons you see in-hospital pharmacists in Thailand doing such a wonderful job is it's the institution that wants to enhance the public health beyond an individual patient's health.
We've noted that, and I think it's important to strengthen the evidence base for what are the motivators and the strategies for improving reporting, as well as trying to understand what the barriers are. A lot of times it comes down to issues of a culture of reporting and quality improvement, promoting ways of helping reduce the time involved in it. And I don't know, Dr. Isah, you might have more ideas, but this is a fruitful area for additional work, both policy as well as research.
Well, thank you. I think that actually brings me to the presentation from Thailand, where, she was talking about medication errors as well. And I was wondering, what is the disclosure pattern, in that part of the world? Because you find that in areas of the world, like the developed countries, the disclosure pattern regarding some aspect of reporting medication errors is open. But when you come to other areas like the developing parts of the world and the stigma attached, it may not be that open. But I think what we should do is to consider reporting of adverse drug reactions as a professional responsibility. just as you said, at making it, part of best practices. In Nigeria, we have just developed what a pharmacovigilance policy, and it's incorporated, it's one of the elements in the pharmacovigilance policy to ensure that, or to make physicians or all healthcare providers appreciate that reporting of adverse drug reactions is a professional responsibility. Thank you.
I think we've got one more question here, and then I want to do a wrap-up with the group.
I'm Godfrey, Professor still from Makerere University, Kampala, Uganda. Still, my question goes to Madam Aarti. These days, we are very concerned with the substandard drugs, and not only looking at the pharmaceutical properties, but also the pharmacological properties. We can't look at the pharmaceutical properties without pharmacological properties, and then we say the drug is of quality. We need to look at both. So is there a way we can go about that?
Thank you for your question. I think the whole issue of substandard medicines, and especially I work in the SADC region, and we are looking at 14 member states. Uganda's not there. And the concern is, whilst there's a perception out there that there's a lot of counterfeit medicines circulating in the market, the evidence doesn't seem to really back that up. It seems to be more around poor quality medicines that are in the market. And I think the important thing that we need to be doing is really creating awareness, understanding the extent of the problem, and then creating awareness of the issue so that we can make sure that we've got a lot of cross-border, people are moving across borders, and medicines are then also moving across borders. And we've had some very interesting examples at the Commonwealth Pharmacists Association meeting earlier this year. Medicines move across country borders as well, and countries have got privacy laws. So it was interesting at the port of South Africa, medicines came in that looked as though they were counterfeit medicines and were moving to our neighboring countries. But because of the privacy laws, the country didn't, they had their own internal network. Regulators work through an internal system. So the issue that you're raising is an important issue, and it needs a multifaceted approach to actually understanding it. And I think what we've seen is that the regulators play a very important role, and it's not just at the time of registration, but the post-marketing surveillance is actually critical. We need to make sure and acknowledge that in some of our regions we are getting the cross-border movement. Patients are moving, they're coming into our clinics, etc. We also need to understand better how medicines are where they are being procured from, and how we are actually ensuring that the medicines are actually of good quality as far down the system as we actually go. And I just want to link at this point the discussions to what Global Fund is doing, because there is it's very interesting that we are harmonizing the quality mechanisms in terms of the donors. But Global Fund was also piloting PSM approaches across countries. And when you're looking at regional initiatives, because each of the RECs, the regional economic communities, especially in Africa, in the EAC region, we've got registration harmonization that's currently underway. In the SADC region, there are harmonization initiatives around procurement, around registration, etc. And there is a recognition that we need to be addressing these issues in the context of the constraints that these countries face. One example, for example, is Seychelles. There's a population of 86,000, and there are just 5 pharmacists in that particular country. So you've got to look at regional initiatives in terms of strengthening systems. And so when Global Fund comes and they speak to the national level, I'm going beyond your question, we need to also look at what is going on at the regional level. We need to understand who are the stakeholders, and we need to understand the supply system across the board, and then we need to understand what are the interventions that we are going to put in place. It's not going to be a one solution answer to everything, but I think we mustn't also blur counterfeits under the whole substandard issue. There's a lot of problems around the actual quality of the medicines that are moving around. Thank you.
Joelle, did you want to comment further on that? Or?
No, I think that I fully agree with what has been done, and I think that all the regional approaches are very important, and we need to promote all of these regional approaches, and also, as you mentioned, not to consider only there is no only one solution, but it's on a case by case basis, of course, but we need to go and to have a broader view of what could be done. Even if we have to answer to one specification, we need also to consider all the context, and the regional context is very, very important. And it was also one of the reasons why at the Global Fund level we do not request each country to have their own quality control laboratory in place with all the structure. It's absolutely not possible, but maybe use a different laboratory in the foreign country, and and each country can have their own specificity, and they can share their own capacity with other countries around, and we really would like to promote this type of approaches.
I just wonder whether would the panel members like to comment any further on what they think are the key either research or other policy recommendations that they would like to see carried forward from this meeting? Start maybe with, would you like to start?
I don't have a particular policy recommendation, but I think in terms of policy implementation, there are important issues to take into account. And I think when we are implementing policies, we need to look at the factors that actually are going to assist implementation. And we've seen from some of our earlier discussions that you need to have champions in place. You need to make sure that you are taking into account the social and cultural factors, and implementation and the success that we will get from these implementation of the good policies are really about the particular context that you find yourself in. And I think due time and regard needs to be paid to that process.
Wimon?
I would like to suggest the policy of the quality improvement of the health sector and medication management must be in the standard of the quality.
In other words, to bring the medication management side of things firmly into the quality assurance within hospitals and health facilities, yes?
Yeah. I've pretty much said a few remarks already about pharmacovigilance indicators, but with the second paper, I'm walking away with a greater appreciation for patient perceptions about quality, and even there's been work done on patient perceptions of what is an adverse drug reaction as well, and what we might define as an adverse event, a patient might interpret that differently. And so I think it's very important to take patient perceptions into account, even in other aspects of quality. On the third paper, I was happy to hear more about the concept of a risk-based approach, which I think merits further review and consideration. And on the last presentation, I'm always impressed with the effects of simple interventions, and things that we actually have known for many, many years. The use of alerts for drug allergies, automating certain things, the training for high alert drugs. Those continue to be lessons we haven't really put into place across the board, but you've illustrated they continue to work. So those are my comments.
Dr. Isah?
Well, I think, will I regard that as a summary? Well, I think the moderator has mentioned most of the points. But as regards pharmacovigilance, I think, just to buttress what he said, that it's now time for us maybe as a recommendation for policy or program action, to have a harmonized set of indicators which should be applied, universally applied or globally applied, to be able to dictate, or let them monitor what is happening within pharmacovigilance systems, and provide trend and be able to intervene appropriately, in the course of time. And they could also serve as advocacy tools to help us build pharmacovigilance, because people do not understand what pharmacovigilance is in many parts of the world, the relevance, and this would be a very versatile tool to be able to market pharmacovigilance.
Joelle, would you?
Okay, thank you. I think that I will remain in the same area of harmonization, of course, and use common approaches. And I would be very interested to know what is the impact of the common approach for the procurement of product when the market is very small. Maybe like we have heard this morning about TB problem, and maybe for pediatric formulation, we know that it's a small market today, and without a common approach, I think that we can lose a lot of patients because the manufacturer will not be able to produce on a small quantity. So I would be very happy to have a study on this type of issue, how to combine all our effort to be sure that even for a small market, the patients are receiving the appropriate medicines.
Well, thank you very much indeed for those contributions. And I think we've had a very far-reaching session today, which didn't forget the simple, but was able to reach for the skies. And now it just remains for me to thank you all for attending and your contributions, one and all. My colleague, Dr. Stergakis, for his excellent moderation, and our and also our rapporteurs. I hope you've managed to capture some of what we said. So it remains for me to wish you all the best now for a pleasant evening and for the rest of our deliberations during the week. Okay. Thank you. The session's closed.